Hi guys, welcome back to my channel, Obgyn Made Easy. In today's video, I'm going to discuss polyhydramnios, also known as hydramnios. So what does polyhydramnios mean? Before we get into that, let's just look at the word polyhydramnios. Okay, so poly means a lot, hydra means water, amnios means amniotic sac. So there's too much fluid in the amniotic sac. Polyhydramnios. This is anatomically defined as when amniotic fluid exceeds more than 2000 ml. On ultrasound, it's when amniotic fluid index is more than 25 centimeters and a deepest vertical pool is more than 8 centimeters. There are two parameters used to determine how much amniotic fluid is there. That's the amniotic fluid index and the deepest vertical pocket or the deepest vertical pool. As you can see in the diagram here, you have the mother's abdomen, the mother's gravid uterus, and that's the mother's umbilicus. We use the mother's umbilicus to divide the abdomen into 4 quadrants. So to measure the amniotic fluid index, you have to add the 4 quadrants together, the amniotic fluid in that 4 quadrants. So you use the anterior-posterior diameter to measure the amniotic fluid index. And in that pocket, it should be an empty amniotic fluid, meaning there shouldn't be any fetal part or umbilical cord. So you add the results in the 4 quadrants, which will give you the amniotic fluid index. So you can see here, the anterior-posterior diameters of the largest empty fluid pocket in each quadrant are added. And the normal amniotic fluid index is about 5 to 25 centimeters. On the other hand, to calculate the deepest vertical pocket, you use 1 quadrant of an empty amniotic fluid pocket. So a deepest vertical pool is a single maximum depth of an empty amniotic fluid pocket, and the normal deepest vertical pool is about 2 to 8 centimeters. Classification of polyhydramnios is based on the severity as well as the duration. So based on severity, you have mild polyhydramnios where the deepest vertical pool is about 8 to 11 centimeters or the amniotic fluid index is 25 to 30 centimeters. In moderate polyhydramnios, the deepest vertical pocket is 12 to 15 centimeters or the amniotic fluid index is 30.1 to 35 centimeters. In severe polyhydramnios, the deepest vertical pool is equivalent to 16 or more than 16 centimeters, or the amniotic fluid index is more than 35 centimeters. Based on the duration, you can have acute polyhydramnios or chronic polyhydramnios. The incidence of polyhydramnios is about 1 to 2% of all the pregnancies, and it's more common in multiparous women than prime gravidas. The etiology is as a result of an imbalance between the absorption and production of the amniotic fluid. Before we look at the causes of polyhydramnios, let's discuss a bit on amniotic fluid circulation. Before we look at the causes of polyhydramnios, let's discuss a bit on amniotic fluid circulation. So where does the amniotic fluid come from and how is it eliminated? So this is the amniotic sac, and the amniotic fluid circulates within the amniotic sac. So remember that by the second trimester, the fetus has started producing urine through the kidneys. So some of the amniotic fluid comes through the fetal urine. Actually, the majority of the amniotic fluid comes from fetal urine. The second way is from the placenta. The third way is through the fetal membranes. That is how amniotic fluid is produced. And this same amniotic fluid circulates within. How? The fetus will swallow some of the amniotic fluid it has produced. It will be processed through the gastrointestinal tract, but some of it will be eliminated again through the kidneys. So as you can see, it's a circulation within the amniotic sac. And some of it diffuses out through the skin as well as diffuses in through the skin. And some of the amniotic fluid is expired through the lungs. It comes out as lung fluid. Fetal anomalies account for about 20% of the causes of polyhydramnios, and the most common fetal anomaly being anencephaly. Anencephaly is a congenital malformation where there's exposed meninges. So there's transudation of fluid from the exposed meninges, which contributes to excessive production of amniotic fluid. The other reason is that there's absence of a fetal swallowing mechanism in anencephaly. So the amniotic fluid that's produced is not being swallowed enough. So there's a lot of amniotic fluid that's surrounding the fetus. In open spina bifida as well, there's exposed meninges. So there's transudation of fluid from the exposed meninges. In esophageal duodenal atresia, this is where there's absence of an esophagus or a duodenum. So this causes prevention of swallowing. Facial clefts and neck masses as well interfere with swallowing. Another cause of polyhydramnios is hydrops fetalis. Remember, hydrops fetalis is a serious condition where there's abnormal accumulation of fluid in two or more fetal compartments of a fetus. So, what causes hydrops fetalis? This can be due to infections like torch infections or parvovirus B19 or cardiothoracic anomalies or fetal cirrhosis. Another cause of polyhydramnios that's fetal related is aneuploidy. Placenta causes of polyhydramnios are chorioangioma. A chorioangioma is a tumor of the placenta. So the tumor grows from a single vellus consisting of hyperplasia of blood vessels as well as connective tissue. So the hyperplasia of the blood vessels and connective tissue results in increased transudation of fluid from the tumor. Remember, we said one of the ways that amniotic fluid is produced is from the placenta. Multiple pregnancy is another cause of polyhydramnios, and it's more common in monozygotic twins, usually affecting the second twin or sac. In twin-to-twin transfusion syndrome, the recipient twin is affected more. This is the receiving twin. Maternal causes of polyhydramnios include diabetes. Where there is increased maternal blood sugar, it will pass through the umbilical cord and increase fetal blood sugar. Remember, where there is increased blood sugar, you have polyuria, and so there will be increased fetal diuresis, which results in polyhydramnios. Cardiac or renal disease also results in edema of the placenta, which results into increased transudation. So increased transudation of the fluid into the amniotic sac. So remember, we said that some of the amniotic fluid comes from the placenta. And of course, 50 to 60% of the causes of polyhydramnios are unknown. Chronic polyhydramnios is more common than acute polyhydramnios. It's of gradual onset and the patient is usually comfortable because they start getting used to the symptoms over time. Symptoms of chronic polyhydramnios. The patient will come in with complaints of difficulties breathing, palpitations or complaint that the heart is racing faster than usual, swelling of the legs as well as varicose veins. The signs you will notice on the patient, they'll be dizzying in obvious respiratory distress, and they might have features of preeclampsia. What are these features? They might have hypertension, a raised blood pressure. There might be proteinuria, so that's protein in urine, and of course the edema. Remember that chronic polyhydramnios can complicate into preeclampsia in about 25% of the cases. On inspection of abdominal examination, you see that the abdomen is very enlarged, it's globular, and there's flank fullness. The skin will be tense and shiny, and the stria will be very large. On palpation, the height of fundus is large for dates. So the height of fundus is more than the expected dates for that patient. And the abdominal girth is large and there'll be a positive fluid thrill. And it will be difficult to palpate the fetal parts as well as the presentation because there's too much amniotic fluid, you can't even feel the fetus. On auscultation, it will be difficult to pick up the fetal heart rate because of the too much amniotic fluid. On vaginal examination, the cervix will be pulled up. It will be difficult to actually feel the cervix sometimes. Or you may find that the cervix is dilated, and if it's dilated, you can actually feel that the amniotic sac is tense and bulging. Investigations of polyhydramnios. Ultrasound is very important. It's important for amniotic fluid index and deepest vertical pore estimation. Remember that amniotic fluid index and deepest vertical pore will help you tell what is the severity of the polyhydramnios. Ultrasound to exclude multiple pregnancy. Remember, we said multiple pregnancy is another cause of polyhydramnios. For lie and presentation, remember we said on examination you might find it very difficult to actually find the fetal part. So you need ultrasound to help you determine the lie and presentation of the fetus. It will also help you diagnose any fetal congenital malformations like open spina bifida and encephaly. Blood investigations include ABO and rhesus grouping. Remember that rhesus isoimmunization can cause hydrops, fetalis, as well as fetal ascites, and these two can cause polyhydramnios. You also screen the mother for maternal diabetes. You do serology for infections. Which infections are we looking for? Torch infections, because this can cause hydrops, fetalis. You assess the amniotic fluid for alpha fetoprotein. If the alpha fetoprotein is markedly increased, this can tell you that the fetus has an open neurotubal defect like anencephaly or open spina bifida. Differential diagnosis of polyhydramnios: multiple pregnancy, yes, pregnancy with a huge ovarian cyst, as well as maternal ascites. Acute polyhydramnios, it's rare, it's of sudden onset, the patient is uncomfortable, so she will have an acute abdomen, usually occurs before 20 weeks, and it's usually associated with monozygotic twins with twin-to-twin transfusion syndrome or choreangioma of the placenta. In most occasions, there is spontaneous abortion that happens. In severe twin-to-twin transfusion syndrome, repetitive amniotic fluid reduction until amniotic fluid index is normal can be done, or laser ablation may cure the cause of twin-to-twin transfusion syndrome. Complications of polyhydramnios. You have maternal complications as well as fetal complications. For the maternal complications during the pregnancy, you can have preeclampsia. Preeclampsia can occur about 25% of the cases in polyhydramnios. You have malpresentation under floating head. Of course, there's too much amniotic fluid in the amniotic sac. So you have malpresentation and floating head. It's like a swimming pool for this baby, eh? You can have premature rupture of membranes. In premature rupture of membrane, this is because of the too much amniotic fluid that causes too much pressure on the amniotic sac. So this too much pressure can actually cause tears in the amniotic sac. So you can end up with premature rupture of membranes. In preterm labor, this can happen either spontaneously or induced. If the polyhydramnios is too severe, you can induce the patient to go into labor to avoid any further complications. And also because of premature rupture of membranes, it can end up into a preterm labor. You can also have placental abruption or what we call accidental hemorrhage. So what happens if you rupture the membranes during labor, if you don't control the amniotic fluid drainage? Sudden escape of the amniotic fluid can actually cause a decompression syndrome and just pull down the placenta with it. So you can end up with a placental abruption. Intrapartum maternal complications of polyhydramnios. So this occur during labor. You can have early rupture of membranes like we discussed above. You can have cord prolapse. So during the escape of amniotic fluid, since there's too much amniotic fluid and there's too much pressure, that pressure can actually draw out the cords, the umbilical cord. So you can end up with a cord prolapse. You can have uterine inertia. In uterine inertia is where the uterus stops contracting at all. So this is caused by overdistension of the uterus. Remember that in polyhydramnios you have overdistension of the uterus, and one of the complications of overdistension of the uterus is uterine inertia. There's also increased operative delivery. Why? Because of too much manipulations, maybe due to malpresentation and also due to artificial rupture of membranes. And also increased operative delivery may be due to a retained placenta. A retained placenta is a complication of polyhydramnios as well as it also increases operative delivery. And you can also have postpartum hemorrhage. Postpartum hemorrhage because of the uterine inertia. Remember we said over distension can cause uterine inertia. So in the postpartum phase you can have postpartum hemorrhage because of poor uterine contraction or uterine atony. In the puerperium phase, you can have subinvolution of the uterus. This is one of the complications of also over distension of the uterus during pregnancy. It can result into delayed involution of the uterus. There's also increased puerperal morbidity due to postpartum hemorrhage, as well as increased operative interference. So you could have introduced infection during your maneuvers or during artificial rupture of membranes. Fetal complications of polyhydramnios include increased perinatal mortality, and 50% are due to prematurity. Remember, one of the complications of polyhydramnios is preterm labor, so the fetus can be premature. And also due to congenital abnormalities, 40% of the cases, and due to cord prolapse. Cord prolapse can cause fetal distress, so that also increases perinatal mortality. Placental abruption can also cause fetal distress, so that also increases perinatal mortality. And hydrops fetalis, remember, is a life-threatening serious condition, so that also increases our total perinatal mortality rate. Management of polyhydramnios. Mild polyhydramnios is common in mid-trimester and usually does not require treatment except bed rest. Whilst moderate and severe polyhydramnios, the management depends on the presence or absence of fetal malformations. So if there's moderate or severe polyhydramnios but there's no fetal abnormality, supportive therapy is the best, which includes bed rest, treatment of associated conditions like diabetes mellitus or preeclampsia. So you treat these accordingly. You can also give indomethacin. Indomethacin is an NSAID. It reduces prostaglandin synthesis. So it works by decreasing amniotic fluid production because it reduces fetal urine output. So you give indomethacin for 1 week if the gestation age is less than 32 weeks gestation age. Because if you give it more than 32 weeks gestation age, it can actually cause premature closure of the ductus arteriosus. So the other benefit of indomethacin is that it's a tocolytic. You can also give it in preterm labor. It can delay labor for 48 to 7 days. If you are suspecting that the baby is premature, this will give you time to give steroids to the baby to help mature the lungs. You can also give steroids like betamethasone or dexamethasone if the gestation age is 26 to 34 weeks gestation age. Remember that complications of polyhydramnios include preterm labor, premature rupture of membranes, and also you might need to induce this patient to go into labor to avoid any further complications. So to be prepared, just give the patient steroid to help with fetal lung maturity. Given the supportive therapy and the patient has responded to treatment, you continue monitoring the patient but you deliver at term. However, if they've not responded to treatment and there's maternal distress and the gestation age is less than 37 weeks, you do repeated amnioreduction till fetal lung maturity occurs. Amnioreduction is done through amniocentesis. So what you're trying to do here is to buy time until there's fetal lung maturity. However, if the pregnancy is at 38 weeks gestation age, it's at term. You can do amnioreduction if the polyhydramnios is too much. And if there's a favorable lie and presentation, you can proceed to induction of labor with controlled artificial rupture of membranes. You have to control the rupture of membranes. Remember, we said we don't want decompression syndrome when the amniotic fluid is coming out. You can do this with or without oxytocin infusion. In both scenarios, remember to do PPH prophylaxis. Postpartum prophylaxis. Remember, one of the complications of polyhydramnios is postpartum hemorrhage. However, if there's fetal abnormality, remember that the management we just discussed above is for a patient with moderate or severe polyhydramnios but there's no fetal abnormality. But if there's fetal abnormality, it's best you refer to a higher dependence unit where there's a maternal fetal medicine unit, and you counsel the patient for pregnancy termination or delivery because of the congenital abnormality the fetus is most likely to have. This comes to the end of our discussion. In the next video, I'm going to discuss oligohydramines. Don't forget to subscribe to my channel. Thank you.